Hi, good morning. My name is Saeed Malik, and I'm the Clinical Director of Transplant Surgery at the Brigham and Women's Hospital. I will be talking to you today about the pre-transplant surgical evaluation of transplant recipients. Here is my small bio and information. So I trained at North Shore Hospital in New York, did a transplant fellowship at the Starzl Transplant Institute, and then moved to Boston in 2006 as the clinical director of transplant surgery. And I've been here since then. My focus is living donor kidney transplants and surgical education. So what do we look at when we are looking at patients from the surgeon's point of view before their transplant? That's what we're going to talk about today. So our concerns are mainly obesity, peripheral vascular disease, any urological issues that the patient may have, prior abdominal surgery is a concern, prior renal transplant, and the need for native nephrectomy. So I'll go over all of these one by one, and would be happy to entertain any questions via email if any of you have them. So body mass index is the most widely used marker of obesity despite its limitations. Some people decided to talk about waist circumference, but overall I think BMI is what most surgeons use for assessment of obesity. And the impact of obesity on outcomes has been controversial, right? Because as you all know, overweight patients on dialysis actually do better. So, why should they be losing weight prior to a transplant? And, registry data has demonstrated a significant survival advantage for recipients of both deceased and living donor transplant compared with remaining on the wait list. However, there are some studies which show that if your BMI is greater than 41, then there's no survival benefit of transplants, although this has also been controversial. There's no question that obesity is associated with increase in wound infection, delayed graft function, and weight gain is more common in moderately and morbidly obese transplant recipients. But in spite of all these things, the patient and graft survival remain unchanged. And a recent analysis of over 27,000 patients from the UNOS database showed that compared with normal weight patients, a BMI of greater than 35 was associated with an increased risk of delayed function, prolonged hospitalization, acute rejection, and decreased overall graft survival. So where are we with obesity? So there are these controversial and conflicting data, some suggesting that there may be decreased survival if the BMI is super high, and others saying that it's still beneficial. So the way we manage it at our institution is that we don't have a cutoff for BMI. Some centers have a cutoff that if your BMI is greater than 40 or greater than 35, then we won't consider you for transplant. So we don't have any strict cutoff limit. And the reason for that is simple, because you can have a 40-year-old female with a BMI of 39 or 40, but has a wide gynecoid pelvis, and when you examine the patient, you can tell that it'll be possible to place a kidney technically. Whereas you can have a male patient with a BMI of 37, muscular patient with a BMI of 37, where all the weight is centered around his middle and his abdomen. And in that person with an android pelvis, it may be very difficult to place a kidney, technically. So we decide on an individual basis, and that's what I would recommend, or what should be the approach. And also, the other thing to consider is comorbidities. So you have a young patient with a BMI of 39 and no other morbidities, that may be well worth doing a transplant on this patient. But if you have a patient who's 65 years old, has a BMI of 39 or 40, has bad cardiovascular disease, has other medical comorbidities, has calcified vessels, and has repeated infections, then you might think again about trying to do a transplant in that patient. So careful assessment of both recipient comorbidities as well as donor risk factors is important before deciding what the cutoff for obesity should be. The next thing I want to talk about is peripheral vascular disease. And peripheral vascular disease is present in about 15% of patients starting dialysis. And clearly, it has been associated with increased mortality. However, stable peripheral vascular disease is not a contraindication for transplant, but patients who have severe bilateral occlusive disease not amenable to correction are not candidates for transplant. So what do I mean by that? So if we have patients who have a history of peripheral vascular disease, who are diabetic, we generally will get a CT scan of the abdomen and pelvis to look at their iliac vessels, specifically the external iliac artery. Because many times you can have calcification in the common iliac artery and in the internal iliac, but the external iliac artery is spared. And that is the area where we plug in the allograft. So as long as that is available to us, then we are okay with proceeding with surgery. So it's important to look at the CAT scan and see if the external iliac is calcified or not. If the external iliac is calcified, again, there are two things. Are there scattered calcification, or is the whole thing like a lead pipe? Obviously, if it's a lead pipe, then that's going to make it impossible to put the kidney in, because you can't really pass your needle through that calcified plaque. So in that instance, one option would be to consult our vascular surgery colleagues, and then they can put a bypass graft extending from the common iliac down to the superficial femoral artery to bypass that calcified segment. And then we can plug in our kidney into that segment. However, that's easier said than done. And again, that decision needs to be made on an individual basis, because when we put in a bypass graft, then that elevates the level of the artery and the vein remains deep down in the pelvis. So there's this discrepancy, and placing the placing the kidney and positioning it correctly can be a challenge. It can get kinked and twisted very easily. Also, patients with calcified vessels usually have bad cardiac disease as well. So you have to factor that in, or the other comorbidities, before deciding on whether this patient is a candidate or not. If there is only scattered calcification, as long as we can find a segment which is free of calcification, we can plug the kidney into that area. Also, if there are like small areas of plaque, we can do an endarterectomy. So we make an opening in the artery, and then we can remove that piece of plaque and then sew the kidney vessels into that area. So those are the options for patients with peripheral vascular disease, how to get around them. The way you look at them is obviously you do a complete history and physical, you palpate the peripheral pulses, you palpate the femoral pulses, and if they're absent, then you can do Doppler flow studies and then either do a CT scan or do an MR angiogram, which is sometimes useful if patients are pre-dialysis and you don't want to give them a contrast load. So that's basically the approach to work up patients with peripheral vascular disease. Genitourinary disease, the incidence of urological abnormalities is low, but if they are present, obviously they require consultation from urology. Many times you see what's called a dysfunctional bladder or an autonomic bladder. Patient has diabetes, they haven't made urine, the bladder is not contracting well enough, so after surgery they have overflow incontinence or dribbling of the urine, and they are more prone to infections. So they need, if that is picked up prior to the transplant, then they can have bladder training and training of their pelvic muscles. They can be taught self-catheterization if they are not able to empty their bladder. But all of these increase the risk for urinary infection. So even though it may seem pretty simple, sometimes these small problems can linger and cause a lot of frustration on the part of the patient later on, because they keep coming back with recurrent UTIs, with urine retention and things like that. If obviously they have major abnormalities, or they have a really contracted bladder which has no capacity, and by no capacity I mean if their bladder capacity is less than 75 ml, then it's impossible to plug the ureter into the bladder. They usually have hypertrophied muscle as well, and the bladder is like a small walnut and no capacity, so then you can't really do the transplant. So they would need something like bladder augmentation or a urinary diversion with an ileal conduit, which are like complicated surgical operations requiring collaboration with your urology and the transplant team. And again, as in every instance, individual assessment is necessary to determine what exactly the patient needs. Most of them will need a cystoscopy to evaluate the bladder. Our practice has been that if we have patients who have not made any urine, who are on dialysis for a long time, we will do a cystoscopy just to make sure that we get an idea of how thickened the bladder wall is, whether there is cystitis or inflammation in the mucosa, and what the capacity of the bladder is. And then based on that, or whatever we find, we can do other things like avoiding cystourethrogram or retrograde pyelogram if you're concerned about reflux and other issues. And obviously, urological surgery will need to be consulted if any repair or other treatment is required for these abnormalities. Native nephrectomy. So when the first transplant was done in 1954 by Dr. Joseph Murray here at the Brigham and Women's Hospital, it used to be the Peter Bent Hospital at that time. It was between two identical twins, as you all know. And what they did at that time was that when the kidney was implanted in the recipient, they removed the native kidneys. However, the practice has gone away from that, although the technique of surgery has surprisingly remained pretty much the same since then, plugging the kidney into the iliac artery and vein, either on the right or the left side. But the need for native nephrectomy has diminished, and it's performed in very select instances. And obviously, if someone has massive polycystic kidneys and there's no room to place the third kidney, then we would go ahead and remove one of the polycystic kidneys, either before the transplant if the patient's already on dialysis, or sometimes it can be done synchronously, meaning that they come in and native nephrectomy is performed, and then the transplant is done usually on the same side as the native nephrectomy, but that involves a bigger incision, and they're more prone to develop a lymphocele and fluid collection. So you have to be careful of that as well. The other instance where native nephrectomy may be done is if someone has, say, Staghorn calculus, which are recurrent infections. So you might want to remove the native kidney prior to placing your allograft. And also in children, sometimes, especially in really small kids, the native kidneys may be removed for some congenital abnormalities, or even if they're not abnormal, sometimes with these children, what happens is that the kidneys are not working, but they are still producing a lot of urine on their own. And then when you add on a transplant kidney, the volume of urine that they produce becomes too much for the little child to handle, and they cannot be forced to drink or understand the need to keep on drinking to make up for the fluid that they're losing in the urine. So they become very dehydrated at times. So in our pediatric surgery colleagues, sometimes they will remove the native kidneys if they feel that there's going to be volume-related issues after the transplant. So those are the instances where native and nephrectomy may be warranted. But other than that, there is none. The indications for native nephrectomy have diminished in recent times. And that is basically everything that I have to share with you. So if you have any questions, please email those to me. My email will be available to you in my bio. And thank you again for your attention. Thanks for the invitation.